So, welcome also on behalf of Luc Theo. Welcome to the fifth of a series of webinars by G-ScarS. And this theme of today is scar management from simple to high tech. And we're privileged to have three well-known speakers for you on the subject of scar management. And that will be Professor Alexis Desmoulière, Professor Franco Bassetto, and Dr. Pieter Zwanenburg. And also on behalf of them, very welcome to this webinar. You might have been with us before, and I would like to ask you, please, send us hello in the chat so that we know who you are and where you're from and that you're with us. So please, if you could let us know by the chat that you're here, it would be great. Also, if you have questions for the speakers, you might let us know in the chat. You can just write your question for the speaker, and I will pick the questions, and they will be addressed by the speakers. So that would be great, and it would be very nice to have an interactive discussion with all of you. Well, let's see. We're now at 3:04, so we'll wait a little bit to start with the first lecture. I already will introduce the first speaker, who is Professor Alexis Desmoulière. Most of the people who work in the field of scar management, they know Professor Alexis Desmoulière. He was awarded a PhD from Bordeaux University in France, and he worked in Switzerland with Professor Gabbiani, and he worked there at the Department of Pathology at the University of Medicine, Geneva. Then he went back to France to work for the Institut Pasteur, and later in Lyon, and then in Bordeaux. And right now he is a full professor of physiology in Limoges. And as many of you know, he is very respected for his research in the field of wound healing, specifically on the myofibroblast and the role of TGF-beta1. So that's we are very happy to have him on board and to let him give his talk. But I think so far. Again, I would like to say, before I hand the word to you, Alexis, please let us know who's on the webinar, and just say hello in the comments. And please let us know in the chat. And meanwhile, Alexis, I'll hand the word to you. I'm very curious what you have to say about the myofibroblast and wound healing. Please go ahead.
So welcome everybody, and many thanks for the invitation and for the introduction. Okay, okay.
It worked. So.
I am waiting for my idea. I think Gabriel is working.
Yes, great.
You just need to go on your PowerPoint on your presentation. You share your screen so you can go on your PowerPoint and you're ready. Yeah.
Okay, sorry, thank you very much again, and welcome everybody. So again, many thanks for the very kind introduction. So the birth of the myofibroblast has been announced 50 years ago in 2 subsequent papers published in Experientia and in Science. And on this occasion, this year, the journal Wound Repair and Regeneration will publish in July a special issue titled Myofibroblast in Wound Repair and Regeneration. And with my colleague Boris Ince from Toronto, we have written the editorial of this special issue, in which we underline the role of Giulio Gabbiani in the discovery of these cells. Here we have the first page of the seminal paper, whose title is Presence of Modified Fibroblasts in Granulation Tissue and Their Possible Role in Wound Contraction. And already in 1988, in this week's Citation Classic Science Citation Index, so I think that pre-internet generations may remember, maybe, list over 290 publications that cite this seminal paper. And today's Scopus reports more than 1,000 citations for this work. And of note, the term myofibroblast was not used in the first publication in Experientia, but only introduced at the very end of the later Science paper. However, our results support the conclusion that fibroblasts, under certain conditions, are capable of modulating toward a cell type that is structurally and functionally close to smooth muscle. For these cells, the name myofibroblast may be appropriate. And now, 5 decades after the myofibroblast discovery, numerous studies have been published elucidating the central roles of these quite enigmatic cells in normal and pathological tissue repair processes. And the PubMed search for myofibroblast delivered more than 70,000 hits today and more than 49,000 hits in the ever so more industrial Google Scholar. So now if we compare the characteristic of fibroblast and myofibroblast, we can see, among several characteristics, that fibroblasts are ubiquitous in connective tissues, while myofibroblasts are essentially present in damaged tissues, fibrosis, and cancer. So as you know, myofibroblasts produce large amounts of type 1 collagen during tissue repair, contract wound margins to facilitate reepithelialization and restoration of tissue integrity, and obviously their persistence contributes to the pathogenesis of fibrosis and cancer. So the myofibroblast is a modified fibroblast expressing a smooth muscle phenotype, which appears temporarily in normal tissue repair situations, but permanently in excessive scarring conditions, including organ fibrosis, in liver, in lung, in heart, etc., including also tumor stroma and hypertrophic scars. So first, in normal situation. So after damage, myofibroblasts appear during the proliferation phase where they participate in the formation of the granulation tissue. And we observed during the formation of this granulation tissue, the migration and the proliferation into the wound bed of fibroblasts, which acquire a myofibroblast phenotype. And these myofibroblasts are responsible for extensive deposition of extracellular matrix and also are responsible for wound contraction. So we see here a typical myofibroblast in culture with alpha-smooth muscle actin present in stress fibers. So alpha-smooth muscle actin is a classical marker to detect the myofibroblast. So the transformation of fibroblast or precursor cells in myofibroblast involves soluble factors and extracellular matrix. But the mechanical microenvironment play a very important role. Indeed, myofibroblasts are particularly strongly linked to the extracellular matrix, as we can see on these pictures. So the main soluble factors involved in myofibroblast differentiation is transforming growth factor beta 1, but extracellular matrix components, particularly the fibronectin domain EDA, are also necessary. And finally, a mechanical tension must be also present in the cell environment to obtain a complete terminal myofibroblastic differentiation. So all these elements are necessary to obtain a terminal myofibroblastic differentiation. Here we have a schematic model of latent TGF-beta 1 activation by the interplay between cell and extracellular matrix. So depending on the extracellular matrix compliance, if the extracellular matrix is soft, cell pulling is not effective and TGF-beta 1 remains latent. But if the extracellular matrix is stiffened, cell pulling is effective and TGF-beta 1 is activated. So the role of the extracellular matrix environment is very important for the myofibroblastic differentiation. Here are illustrated again the connection between fibroblast, myofibroblast, and the extracellular matrix, and also the importance of macrophages is underlined. So again, we have a soft extracellular matrix, we have fibroblasts or myofibroblast precursors with no alpha-smooth muscle actin stress fibers, and these cells have low or no contractile properties. In contrast, in stiffened extracellular matrix, we obtain typical myofibroblasts with stress fibers expressing alpha-smooth muscle actin, and these myofibroblasts are able to contract and produce important amount of extracellular matrix. So in this transformation, obviously TGF-beta 1 play a major role, and in major situation, macrophages secrete TGF-beta1, allowing the transformation of fibroblast in myofibroblast. And the role of macrophages is also important to modulate the extracellular matrix composition and also biophysical state. So the main actors are fibroblasts, myofibroblasts, and macrophages together with the extracellular matrix. So during resolution phase and scar formation, we can observe in normal situation typical features of apoptotic cells with chromatin condensation, donc not only in apoptotic myofibroblasts, but also in apoptotic endothelial cells. Indeed, during a scar formation, during normal scar formation, cellularity decreases and vascular tree is reorganized. So myofibroblast and endothelial cells die by apoptosis. And here, interestingly, we have a macrophage containing an apoptotic body with the typical nucleus of an apoptotic cell. Here we have the nucleus of the macrophage, but here an apoptotic body, and apoptotic bodies containing alpha smooth muscle actin, so deriving from apoptotic myofibroblast, are also observed in macrophage. So macrophages are able to eliminate apoptotic bodies deriving from apoptotic myofibroblast, because these apoptotic bodies contain alpha smooth muscle actin. And in parallel, extracellular matrix is remodeled during normal scar formation, and collagen fibers appear like thread cords with various diameters, like detwisted fibers. So on this illustration, we can see during proliferative phase the migration and the differentiation of fibroblasts in myofibroblasts expressing alpha smooth muscle actin and able to contract the wound. And during resolution phase and normal scar formation, again, myofibroblasts, but also endothelial cells partly die by apoptosis. So obviously, in a pathological situation, apoptosis is not present in myofibroblast. So these myofibroblasts do not disappear and continue to proliferate in the pathological tissue. So we will discuss this point later. So concerning myofibroblast precursors, so in the skin, we have two dermal fibroblast population, reticular and papillary, which have distinct functions during tissue repair, whereas papillary fibroblasts do not express alpha smooth muscle actin and are involved in the regeneration of skin structures, such as hair follicles. Reticular fibroblasts differentiate into collagen-producing alpha smooth muscle actin expressing myofibroblasts by, again, the action of biomechanical, so extracellular matrix stiffness, and biochemical factors such as TGF-beta1. In some specific conditions and in experimental models, myofibroblasts can also arise from epithelial and endothelial cells via epithelial to mesenchymal or endothelial to mesenchymal transition, respectively, and also from mesenchymal stem cells from pericyte and pre-adipocyte or adipocyte. So we have different sources for the myofibroblast. The main sources remain the fibroblast present in the skin. So the myofibroblast can appear permanently in pathological conditions, excessive scarring conditions, including organ fibrosis, tumor stroma, and hypertrophic scars. For example, in liver fibrosis and cirrhosis, the collagen deposition and the organ contraction also is due to the presence of myofibroblast expressing alpha smooth muscle actin. In the normal lung, classically, TGF-beta1 is latent, but in fibrotic lung, very interestingly, it has been shown that breathing induces mechanical TGF-beta1 activation from established fibrotic tissue. So obviously, it is not possible to stop breathing to avoid mechanical TGF-beta1 activation, but therapeutic intervention may be possible by targeting the cell side of mechanical TGF-beta1 activation. We will discuss rapidly this point later. Now in tumor stroma, here in cholangiocarcinoma, as in many tumors, the very strong extracellular matrix deposition is due to myofibroblast, which again here express alpha smooth muscle actin. And now in the skin, in basal cell carcinoma, we can see here alpha smooth muscle actin expression in myofibroblast of the tumor stroma around invasive tumor cells. And it's important to realize, as you know, that for a curative surgery, removal not only of the epithelial tumor, but also of the tumor stroma is necessary. And the stromal dependency is very important. It is linked to the capacity or not of these skin tumors to develop metastasis. So the dialogue between tumor cells and myofibroblast is important for the development of the tumor. And of course, numerous myofibroblasts are present in hypertrophic scars. And these myofibroblasts, these contractile myofibroblasts expressing alpha smooth muscle actin, are involved, of course, in the pathogenesis of scar contraction. And in hypertrophic scar with no treatment, particularly no compression treatment, the dermal epidermal junction is completely disorganized. And we have seen that under a compression, so only a mechanical treatment, a progressive reorganization of the dermal epidermal junction is observed. So again, it underlines the importance of the mechanical signals in processes involved in myofibroblast differentiation, but also in here hypertrophic scar development and hypertrophic scar resolution. So a point which is often a discussion topic, true keloids are definitively, as you know, excessive scarring situation, but true keloids do not contain myofibroblast and so do not contract. So I know that this point is always a discussion topics. So today, the myofibroblast activation pathways are relatively well known. So we see again the major role of biochemical signaling and of biomechanical signaling, leading to myofibroblast activation. The myofibroblast survival and apoptosis pathway are also relatively well known. So we have again a balance between pro-survival signaling, so again extracellular matrix stiffness and TGF-beta1. So a balance between pro-survival signaling and pro-apoptotic signalings, with the importance of the important role of different type of keratinocytes. So today, different antifibrotic therapies are developed, and we find again the well-known targets. So inhibition of TGF-beta1 activation, inhibition of mechanotransduction. So many assays are in development today. And finally, the last target is the activation of apoptosis pathway. Obviously, in some pathological situations, such as chronic or difficult to heal wounds, it is necessary to activate myofibroblasts. And for example, it is well known that negative pressure therapy is able to induce granulation tissue formation and myofibroblastic differentiation. So myofibroblasts are necessary for tissue repair, but they must disappear when the job is done, if not pathological situations developed. And just to conclude, I would like to tell you that we are now working on the role of innervation in skin repair. So we are studying the interaction between neuron endings, so in the skin, the capillaries, and mesenchymal stem stromal cells located around the capillary. We think that these interactions play an important role for tissue repair in many organs, and particularly in skin. So many thanks for your attention.
Many thanks, Alexis. A really great talk, and it was great to have an overview of all the developments, and it's already for 50 years. You called it a golden wedding between Gabbiani and the myofibroblast. Interesting link. For me as a clinician, it was really great to have such a talk, and it really inspired me to think about a lot of clinical cases. And in the beginning, I missed the comments from the audience, and we have audience from all over the world, which is really great to see. And you already have, Alexis, 12 points from Belgium, from Oscar. So I think that's related to the Eurovision Song Festival, but anyway. So now we have also some serious questions here, and a really interesting one from Padua, from Carlotta Scarpa, which is on, which apparently is just recently published in Nature, and there is a relationship between stiffness and breast cancer development. And from Padua, there was the publication, and they want to know your opinion about the relation between well, the stiffness and breast cancer development.
So I have underlined the publication concerning lung fibrosis. So I think that in breast cancer, also we have both the role of tumor stroma around tumor cells, but maybe in parallel we have also the stiffness, the specific stiffness of the breast, which is also working on myofibroblasts. So I think that maybe in this situation, both tumor stroma development or tumor stroma development is due both to tumor cells and to mechanical environment.
Yeah. Okay. Thank you. And there's also a question from Esther Middelkoop. Well, you know her very well. And her question to you is, dear Alexis, is there a difference in proliferation between normal fibroblast and myofibroblast?
It's an interesting question. I don't know indeed. I think that in normal situation, myofibroblast, the proliferation of myofibroblast decreases definitively. But in a pathological situation, so myofibroblast proliferation is maintained. But I don't know. I don't know if we have specific differences between fibroblast and myofibroblast proliferation. Certainly, the pathway are different, but at the moment, I don't know.
Well, if you don't know, but I think that's a very honest and clear answer, and I think it's also a sort of invitation to have more research on this, because I think it's a very relevant question. We have to proceed, but first I want to have time for some other questions which I just saw. Here is from Mariana Altomare. Do you agree? I think I have to. Do you agree that can exist myofibroblasts in normal tissue? I think she means, are there myofibroblasts in normal tissue? I think that will be the question.
Yes, in some specific situation, we can observe a sort of myofibroblast in normal tissue. For example, in around seminal tubes to allow the proliferation of spermatozoids. We have some cells we are looking like myofibroblast. So in some specific, very rare specific situation, we can describe some cells looking like myofibroblast.
Okay. Okay. And we hear from Kenneth Dolinchuk. Are levels of tissue transglutaminases higher in myofibroblast as it is associated with hypertrophic scar proliferation?
It's a good question. I don't remember exactly. Many publications, many works have been published in this domain, but I think that yes, transglutaminase is elevated during myofibroblastic differentiation. We have published some years ago papers in liver fibrosis showing that transglutaminase levels are increased during liver fibrosis and myofibroblastic differentiation. Yes.
Mm-hmm. But then is it a cause or is it a result of? I think.
it's part of the dialogue between extracellular matrix and myofibroblasts. So myofibroblasts secrete extracellular matrix, and the extracellular matrix is acting on myofibroblasts. So it's sometimes difficult to know where is the egg. So I don't know. I don't know if it's sucrose or I don't know.
There's more research needed to
Yes, definitively.
Okay. I was triggered, I think, by many things you mentioned, but also by the difference between the papillary and the reticular fibroblasts. And there's clearly a difference. And I must say that from a clinical point of view, doing some research also on myofibroblast, we also noted the difference between both. Do you have are they really that different, the reticular and the papillary fibroblasts?
So there is a very nice paper published in Nature. It's a group in England. They have shown that definitively, it seems, papillary and reticular fibroblasts are completely different. The studies is very strong, very important, and again, when in experimental full thickness wounds, we can observe that it seems myofibroblasts are coming from the down, from the
from the bottom of the wound.
Yes, exactly, from the bottom of the wound. So it seems clear that myofibroblasts participating in wound healing are coming from reticular fibroblasts.
Yeah. And it's also interesting if you want to prepare, for instance, a living skin substitute, wouldn't you prefer then to only use the more superficial, the papillary fibroblasts for culturing cells?
Yes, this point is very important, and exactly.
Yeah. Well, thank you so much, Alexis. It was really a great talk. But we have to move on and to the next.
Thank you very much.
Yeah, thanks. So it's a great honor to introduce Professor Franco Bassetto, who works in Padua, where he also was graduated in 1984. And he also specialized there in plastic reconstructive and hand surgery. And also, I think a very interesting field is that he does a lot of work in humanitarian missions. He went to India, Angola, Kenya, and he clearly has also an interest on tissue engineering, wound healing, burns, skin cancers, and a lot of innovative research. Nowadays, he's the chief of the Clinic of Plastic and Reconstructive Surgery in Padua, and he published more than 150 papers. And Franco, we are eager to hear from you.
Thank you, Paul. Thank you very much. I am a clinician, a plastic surgery like you, and really I have to thank Alexis Desmoulière for his understanding lecture that permit to us to understand better what we see in our clinic daily and in our patients. My topic will be try to share with you my experience in new clinical technologies that permit the control of fibroblast proliferation and the coverage by keratinocytes of normal and pathological healing, trying to arrive to understand better how we can control the hypertrophic scar that it's modeled by myofibroblasts, as we have seen. Scarring is a very challenge for plastic surgeon, but surely a new era began when was introduced the concept of mechanophysiology. We know, as Ryogawa published more than 10 years ago in Wound Repair and Regeneration, that following skin injury, the mechanophysiological conditions are drastically changed by wound healing, because we can see a granulation tissue, a new tissue formation, a wound contraction, and a new epithelialization that we must to know how they happen. So my topic will be focalized on fibroblasts and keratinocytes modulation that, as we have seen, are obtained by cytokines and growth factors control in scarring. So surely, scarring is a complex process involving many cell types, but the fundamental role of cytokines and growth factors in a mechanobiology context permit to us to understand better how we have these phenomena one after the other that are the stones of wound healing. The hemostasis, the inflammation that, if it prolonged, arrived to the chronic wound, the granulation and angiogenesis phenomenon, the reepithelialization by the keratinocytes advancement, and at the end, the tissue remodeling that we can control in many different ways, like, for example, elastic garment, as we have seen in the previous lecture. So what is the role of the plastic surgeon? Surely try to prevent, if it's possible, pathological scarring, or treat physiological scarring to have the best results. I have the honor to take part, to be a member of this G-ScarS group that for many years it's involved in this problematic, with a continued exchange of idea, basic science, and the clinical findings. And as we can see, we have a product, the scar management practical guidelines in 2014, and now we are working for arriving to a new publication, I hope for 2024, having a regular publication every 10 years. And if I think what has happened in these last 10 years in this topic, we can find a lot in technologies, in basic science, and in even in surgical therapy, in the control of the hypertrophic and bad scarring. But surely having the possibility to take part to this final product of our group, that it's this textbook that was mentioned by other member in other webinar, it's a challenge that we have, that I suggest to everyone to understand better the state of the art management and the emerging technologies for scarring control. In this book, my group was particularly focused on the fat injection, that it's a surgical technique for this control. But I have to share with you the technologies. I want to begin with the milestone of mechanobiology, that was this Donald Ingber product that I knew in Padova. As Alexis told, the history of myofibroblast began with Professor Gabbiani, that was a very good friend of Professor Mazzoleni, that was my teacher, my professor, and with them I understood better what was behind this possibility to understand scarring through a new proposal that passed through the mechanobiology concepts. In other words, we can see here the simple subject that if a cell shape changed during in a mechanobiological ambiente, the cell changes its function in terms of apoptosis, differentiation, and growth. And if we go deeper in this concept, the mechanotransductional signaling pathways that are fundamental for a clinic like me, for a plastic surgeon that have to know what they are doing in their daily activity in the operating room, treating scarring, treating keloids, treating hypertrophic scar, we must know the basic science that pass through the fundamental knowing of the hypertrophic gene program, the function of the beta adrenergic receptor, the function, the change of the ion channel, the function, what happened when a cell shape changes, the assembly of the sarcomeric protein inside the cell, the cell-to-cell communication, and then the concept of cell survival and apoptosis, which are the technologies that I want to share with you. Two of them. The first is called closed portable incision negative pressure therapy. It's a mechanobiology device that permits, through the use with a single use, to have a negative pressure on a field in which we can obtain. Here you can see two different proposals by the market. They are portable devices, so very easy for the patients, in which what we see in our daily practice is the improvement of scar quality if we use them in the first period, during the inflammation period, exactly after the end of the surgery, when we put the final stitches. The easier post-operative management by the patients in the first week, the control of exudate and inflammation, and the reduction of complication in high-risk patients that we have seen at the end of our experience when we understood that these devices are fundamental. But what we have seen during the other 2 years of observation was the improving of the quality of scarring. This is what happened when we put this incisional negative pressure at -80, that it's maintained on the surgical incision for a maximum of 7 days, that removes exudate from wound bed by absorption and evaporation, and that is very easy to be used on patients for the small dimensions and the high compliance by the patients. Here you can see some clinical case. This is a breast surgery in a breast cancer in a patient that went before through radiotherapy. So this is a high risk of Diogenes injury that now we treat with this system of negative incisional therapy for 7 days immediately after surgery. Or this is a very nice and particular anecdotic case that I have seen and published even in PRS. These patients had a Munchausen syndrome. I don't know if you know what it is. It's something that it's very rare. It's a psychopathology in which the patients don't accept a surgical injury, and it tries to complicate it, trying to put here finger, or trying to don't arrive to a normal healing. We have these patients. We understood after 2 or 3 attempts that he may be, and the psychiatric counseling permit to us to understand that he has this psychological syndrome, and we decide at the end to do another surgical attempt on a simple, as you can see, incision for a mini abdominoplasty. And using this kind of incisional negative pressure, we arrive for 7 days to cover the injury. And when the patient tried to interrupt this healing, it was too late, and it arrives at the healing. So I think that this is a very clever tool, a very clever device that we can use, for example, in complex abdominal lesion. These patients had a pancreatic cancer, so he had a diastasis very huge to treat with traditional negative pressure. Then through a movement and intersection of different local flats, we had no other possibility in such very compromised patients. It was mandatory to use the incisional negative pressure for 7 days, and the patients arrive at 7 days and definitive healing without any diastasis and without any complication. But trying to go back to the quality of scarring that we can control in this patient, this is another extreme patient that I received from another hospital. He had a third recurrence of a severe Laparcell with a failure of the device, the mesh, that 2 times was put by general surgeon to treat this Laparcell. What we did was to remove the second mesh, as you can see by the picture, and to put another particular mesh with a biological face on the ball and with a nylon and synthetic mesh on the top, and using the separation of the muscles, we arrived to a definitive coverage, a definitive heal and definitive reposition of this Laparcell. But this patient was at risk of diastasis, so we decided to use the incisional negative pressure therapy device, and he arrives to have no diastasis, no complications, but 4 months post-operative, you can see the quality of this scar, even if it was realized under tension, because we had the forces, the internal forces of the evisceration. So this was a test to understand that really there is a very important influence on the quality of scarring with this kind of tools. And here you see our publication of our book, our group on aesthetic plastic surgery, in which we compared 2 groups of similar patients that went, all of them were post-bariatric patients. They went through a brachioplasty combined with liposuction. We know that brachioplasty, unfortunately, is a site when we can have hypertrophic scar, bad scar, or keloids that patients don't accept. All of these patients were operated in a combined operation of brachioplasty and mastopexy. And in one, we use incisional negative pressure. In the other, no tools was used to prevent complication or to influence the quality of scarring. And here you can see some clinical case in which you can see these patients that after a gastric bypass lose from 132 arrive to 49 kilograms. So condition completely different of the skin, of the dermis, with loss of elastic fibers, and a very revolution on the quality of skin, on elasticity of the skin. And here you can see the use of this device at the end of surgery, and the morphological result. And if we go here, we can see that even the quality of our scar was more acceptable in patients that went through the use of incisional negative pressure. Another patient in which we can see another property of this device, that is the prevention of dilutions through the absorption of serum, blood, or what happened in the first days after surgery. At the end, even preventing this phenomena, we can have a good shape and a better quality and better results. But trying to go to the first question, which are the technology that can influence more actively fibroblast, myofibroblast activation, and keratinocyte progression. Our last experience was with fluorescence light energy. Fluorescence light energy is based on the unique ability of light accepting molecules, chromophores, to translate light emission from a lamp, the so-called blue lamp, in a different photons emission with broader wavelength spectra and lower energy. I was very fascinated from the beginning by this non-invasive technology, because I understood from the beginning that different specific wavelength with different colors surely have different action, different activity on the different biologic effect. Yellow and orange modulates inflammation. Yellow and orange modulate fibroblast proliferation. The green modulate collagen production. The mix of yellow, orange, and green modulates the growth factors, and we know that this light has antibacterial effects. This activity was studied in the lab by Giovanni Scapagnini, that demonstrate the anti-inflammatory effect of fluorescence light energy in animal model. And one of the explanation is explained in this paper published by our group in Padova and Ferrara, in which we try to understand which is the key of the success of this fluorescence light energy. And the answer was maybe the mitochondria. Why? We know that mitochondria are a source of cellular energy. They are responsible for the control of cellular stress, and they are involved in many diseases. What was demonstrated by our basic researchers that are part of the group of Professor Abatangelo, very well known for hyaluronic acid, but that now in his group he's seeing other land of interest, other field of interest in a very good relationship with plastic surgery, with the clinician. We have the needs, and we ask to the basic scientists to give to us the answer of the clinical results that we see. And what they demonstrate, that during the effect of fluorescence light energy, there is an increase in number and dimension of mitochondria of dermal cells, an increase in number and dimension of mitochondrial crests for ATP production. In other words, there is like a new energy in mitochondria in every kind of cells involved in wound healing. And maybe for this reason, we have a new energy for wound healing and a new energy for controlling inflammation that is fundamental for the quality of scar that we can obtain during the remodeling period. Another group that studied fluorescence light energy demonstrated that maybe there is even another key that it's fundamental, that it's neoangiogenesis inducted by this energy, and the collagen deposition and myofibroblast activity, that in other words, it's production and the reorganization of collagen fibers, the control of bad scarring, of pathological scarring. The basic of this study was even in our labs, in which we have seen at the electronic microscope a reduction of myofibroblast activity that explain the better scarring that we see in clinics. And here you can see some huge cases treated in my department, a chronic wound post-corticosteroid infiltration that was not solved with local flap, with necrosis, and so on. After 2 months of treatment, these patients arrived to heal. And controlling the follow-up, this healing was not a pathological, but like a physiological healing. Even the control of perineal suppurative hidrosadenitis was controlled by flap nowadays, and we are working with Marco Romanelli with this clinical subject. But look to this case that is very, very interesting. A chronic wound that was covered in the bone exposition with a microsurgical flap. As you can see here, we have a grand dorsalis with the skin island and with the graft that we put around this flap. We can see that after 2 and 3 months, where we put the grafts, we have these black islands that maybe were related to the activation of the melanocytes line. So this is another demonstration how the fluorescence light energy is acting at many levels in all cells that are included in wound healing. Last but not the least, this the last publication of our group involved in research on fluorescence light energy, even with Luc Theo, and it's the evaluation of fluorescence light energy for the treatment of acute second-degree burns. What we have seen is that flap therapy is easily applicable, safe, non-invasive, targeting and balancing several phases on wound healing and tissue regeneration to arrive a good quality of scar in time. And here we see a patient treated after 4 section, and the dorsal side of the hand that arrived to an healing in a short period with a quality of healing that is maintained good for a long time of follow-up. Another field of interest is the control of scarring in breast surgery, and here is these are the results of a Greece group that demonstrates the difference of the vertical scar in breast surgery treated and not treated with fluorescence light energy. What are we doing now with this technology? the control of hypertrophic scarring and their symptoms, like erythema, like itching, like the severity of the quality of scarring. And we are now collecting very good new clinical results that are that are still on collecting. We didn't publish anything on this topic. And here you see the control of a hypertrophic scar of the thoracic wall that we can find very easily after a thoracocardiac approach. Here you can see how the hypertrophic scar tries to change, especially in this part. You can see after 6 treatments for 3 weeks and after 2 months of observation. So in conclusion, I am a clinician. I have technologies that I every day can use in operating room and in the follow-up of our patients. And my impression is that fibroblasts and keratinocytes modulation by cytokines and growth factors is the key to prevent pathological or treat physiological scarring. Currently, technology in my hand as closed incision, portable NPT, and fluorescence light energy have to be considered when we face high-risk patients, such as, for example, post-bariatric and burnout patients, or high-risk procedures, for example, breast surgery in irradiated patients, abdominal surgery, or cardiac surgery. Thank you very much by all my group from Padova.
So, thank you very much, Professor Bassetto. We do have some questions, good questions from the audience. Due to the time, I like all these questions, so we go through them, but I think we should not go too much into discussion about it because of the time. First, there was one from Alexis Desmoulière. Do you think that abnormal inflammation process could be involved in the development of hypertrophic scarring? So
no, I didn't. Do you think that
the abnormal inflammation process could be involved in hypertrophic scarring?
Yes, I think so. I think that surely, if in the future we could arrive to a gene control, maybe this could be the key to prevent the pathological scarring. Surely we have some population at risk for pathological scarring, black people, or we have some sites that are at risk. For example, the mediasternal or the earlobe, but in many cases we don't know exactly if our patient will be candidate to an hypertrophic or bad scarring. So it's I think that we have to consider this device to prevent it.
Okay, thank you. Professor Esther Middelkoop wants to know, she mentioned that there are different settings, for instance, 125 and 80. What determines the most suitable pressure in your opinion?
As you have seen, we had experience in both devices that we have in the market. The first one has a range of pressure minus 80, the other higher, that rises to 125. Our clinical experience was better if you maintain minus 80. So we have seen that the white one is better in clinical experience than the black one, Padova experience.
Yeah. It might also be related to different things than the pressure itself.
Yes.
That must be okay. But so for now we can say Padova experience 80. Okay. How to prevent the complications of negative pressure therapy, such as skin maceration?
Oh, surely skin maceration is very rare. In other words, we know that the quality of both sponge that we use, the white one and the black one, has very good property of absorption, and so generally you don't have skin maceration. But in such very rare cases, the patient after 3-4 days say that he has pain, or for example itching, or sometimes the negative pressure is not working more and the alarm begin to ring. So in such case, if you find maceration, you have to remove that sponge, because maybe you have too many production of serum and so on, and the sponge is not enough for absorb it. So the suggestion is to remove it immediately. On the other hand, some patients say that during the night, in the 3rd or 4th days, suddenly the tools doesn't work and the alarm begin to ring. So we say, if you don't have pain, if you don't see blood color or such kind of complication, please leave it, because it's a good condition. It's a good medication.
Okay.
A good dress that permit to stay for 7 days in our injury.
Thank you. And the last one is by Smith. Do you believe that the presence of foam or a greater degree, I think a high degree of negative pressure, could lead to better outcomes?
No, it's the same question that I think that 80 is the ideal in our experience. In the control of the first 7 days, in the prevention of diations and complication, but even in the quality of scarring that we had at a long time.
Yeah. Okay. Thank you so much. And we have to move on to the last speaker, but thank you from Padua, Professor Bassetto. So we move on to the last speaker of this webinar, which is Pieter Zwanenburg. I can pronounce his name correctly because he's also from Holland, and he's in fact from the same area as I am, from the Amsterdam area. He is a medical doctor with interest in reconstructive surgery and wound healing, and works closely to Amsterdam in the Ter Gooi Hospital. And in addition to clinical activities, he is also a researcher in the field of negative pressure wound therapy. So he's an ideal speaker for today's topic. Well, please, Pieter, go ahead.
Well, first of all, I would like to thank the Global ScarS Society for this invitation to present our work here, which regards the influence of incisional negative pressure wound therapy on scarring. Paul introduced me, so yeah, I don't need to go over this. Some disclosures. My professor, she has received institutional grants from 3M and KCI, and I've been a speaker previously for negative pressure wound therapy related events sponsored by 3M, KCI, or GD Medical Pharma, which is a distribution company for negative pressure wound therapy. As background, each year surgeons create a whopping over 200 million incisions, which is a really large number. And some of them, unfortunately, develop problematic scars, leading to functional impairment or even chronic pain, itch, disfigurement, and they can become a psychological burden to the patient. Now, in the US alone, over 170,000 scar revisions are performed each year. So it's a clinically relevant problem. And one technique that aims to reduce problematic scars is incisional negative pressure wound therapy, which is negative pressure wound therapy placed on primarily closed surgical incisions in sterile conditions for the prevention of post-operative wound complications. There are several mechanisms First, it acts as a barrier against external contamination. The foil of the negative pressure wound therapy dressing is impermeable for viruses and bacteria. And I think that's a very important mechanism. In addition, the subatmospheric pressure reduces dead space, so less opportunity for seroma accumulation. And also, if there is traffic of any fluid through the wound or incision, it is one-way traffic only from the depth of the wound to the periphery, away from the wound, and not from the external skin flora into the inside of the wound. And also, studies show that if you apply negative pressure wound therapy to intact cutaneous skin of healthy volunteers, or even surgical incisions, that it increases the local microvasculature in the wound. Now, if we take a look at surgical wound healing, I looked it up. I was looking for human data, and human data specifically, and I found a study where they created incisions, simple 5 centimeter incisions in healthy young men, and they looked with the electron microscope when there was complete re-epithelialization of the incision. Now, they said in that study that it took 5 days, and that's in healthy young individuals. And we know from a lot of other studies that it's prolonged when you have diabetes, or you're a smoker, or you have obesity. And yeah, until re-epithelialization has occurred, a wound remains susceptible to bacterial colonization, increasing the risk of surgical site infection. In addition, biofilm formation can occur within days, especially if you have implantable biomaterials in the wound, for example, implants. So yeah, this period prior to re-epithelialization is a critical time period. And I think the barrier function of incisional negative pressure wound therapy is it's a large part of why it works for the prevention of surgical site infection. Now, we have taken a look previously in 2020 already, where we took a look at the clinical studies where we identified 30 randomized controlled trials and 50 observational studies. Here we did a meta-analysis for the individual wound complications, and there we identified a high level of evidence, 28 randomized controlled trials, to suggest that it really reduces surgical site infection. And we identified a high level of evidence, even in subgroup analysis of blinded outcome assessment studies only, the effect remained significant, so we did not evaluate for risk of bias. And also there was a sufficiently large number of patients included in a meta-analysis, so we did not evaluate because of imprecision concerns. And yeah, there's a lot of data available. So yeah, we identified a high level of evidence, and I really think it works. Also, because we also did a meta-regression analysis, which is you can analyze several study characteristics and see if they significantly correlate with the efficacy of the intervention. And there we identified a significant correlation between treatment duration, where we identified the longer, the better. And I think this relates also to the re-epithelialization period. You maybe want to give negative pressure wound therapy for a sufficient large enough amount of time to bridge this critical time period. Now, also, this suggests what Grade calls a dose-response relationship. If you see a relationship between dose and intervention efficacy, then this is a really strong argument that the intervention is really efficacious, and it's not the result of bias or anything else. So this is also a strong argument that the intervention really works. Now, we also took a look at wound dehiscence. Also, we saw a significant effect. However, we had imprecision concerns, and many studies did not use definitions of their outcomes, so we devaluated. So the evidence is of low level, but given the nature of the intervention, I think it's very plausible that it leads to decreased amount of wound dehiscence. Now, we also took a look at skin necrosis, seroma, and hematoma formation, and there we saw that the observational literature suggests that it's also affecting skin necrosis, which would also be plausible if you take a look at the increase of perfusion seen in other studies, and also a increased seroma formation, but these findings are very low level evidence. Now, if we look at the influence of incisional negative pressure wound therapy on scar formation, and we look at the reduction of postoperative wound complications alone, then merely this in itself will lead to better scars on a population level. We all know that if a patient develops a wound infection or a wound dehiscence, you don't get the optimal result you would like to see in your patient. But in addition, incisional negative pressure wound therapy in itself, because of the subatmospheric pressure, it mechanically stents the tissue, reducing mechanical stress. And we know from other studies that this leads to better scars, and increased tension leads to less optimal scars. So, and even if we look at clinical studies from other similar interventions, similar in the sense that they reduce mechanical stress on an incision, for example, here they use adhesive strips versus controlled dressings, which resulted in significant results. Of note, this was a within patient-controlled study design, which is very good methodology. And I think if this works, well, then negative pressure wound therapy should also work. Of note, though, the intervention was given for 5 weeks in this study, and most clinical studies that use negative pressure wound therapy, they only provide it for 7 days or so, or even less. Some studies they use 3 days. But I think it's clear that there is a logical rationale behind incisional negative pressure wound therapy being effective for the improvement of scars. Now, we took a look at the evidence regarding this in our study, where we took a look on the more immediate, the direct effect on the scar formation, where we identified 6 preclinical studies and 9 clinical studies. The preclinical evidence identified 2 computer models, and although they are merely computer models, I think it's very plausible that they are correct, and they show reduction of mechanical stress. If we look at the histopathological studies, there they witnessed a decrease of scar width, or actually granulation tissue width, because these outcomes in the experimental studies were evaluated really early on after the surgery, something like 40 days, for example, and not after 1 year, which you would ideally want to see. But still, it's suggestive of a treatment effect. And also, if they try to pull the incisions apart, they saw that the wounds treated with negative pressure were more difficult to pull apart than the non-treated counterparts. Now, we also identified the clinical evidence. We identified several studies using a huge heterogeneity of scar scores, something you see very often in scar literature. They looked at patient scar satisfaction, and there you saw improvement, also after 1 year. And in the study by Tenaiden et al., you saw a trend that the longer after the surgery, the less obvious the treatment effect becomes. And I think if you take a look at these study sample sizes, I think if you want to detect an event of effect after 1 year, you would really need a larger amount of patients, because otherwise you would be underpowered. Studies also assess the observer scar satisfaction using again a variety of scar scales. Unfortunately, the studies did not mention the results of the individual domains, for example, itch or pain or aesthetics. So that's that's something that was we could not really say anything about, unfortunately. Also here we saw the trend that the longer after surgery, the more difficult it becomes to detect a difference. And 3 studies did not detect any difference. This is also a very interesting study. Here they also did a within patient-controlled study design, similar to the previous study where they used the adhesive strips, but then with negative pressure versus a film dressing. And there they also applied the intervention for 5 to 6 weeks. So a lot longer than most clinicians currently do, because they only do it for 1 week or so. and there they measured objectively decreased mean scar width at 6 months. And I think this is really, really suggestive that the intervention will really be effective, given that you provide the intervention for a sufficient amount of time. Now, for discussion, the evidence on scar formation, the preclinical studies, well, they were relatively short follow-up, which is because it's less feasible in an experimental setting to do such long follow-up times. A lot of industry funding, it's something to be concerned about, obviously. You've seen it in my disclosures. The industry is, of course, very involved still. I think sometimes people, they're so cautious of the industry that they don't believe anything anymore. I still think if you look at just how the working mechanisms of the intervention, then it should work. So I still believe the intervention works. Nevertheless, the evidence was of low level because of the previously discussed limitations. And also something to discuss. I think 1 week is maybe enough if you have adequate speed of reepithelialization and you want to prevent surgical site infection. But if you want to really improve the quality of your scar, I think you would need to give the intervention for, I think, 5 to 6 weeks. And I think maybe you would need separate device, one device for the first week, and then another device for the week 2 up to week 6, where you have a device that is more evaporative of liquid, so you don't get the skin maceration previously mentioned, and also maybe something that you can, as a patient, you can pool vacuum yourself, similar to the SNAP system. Maybe you've seen it, but I think that will prevent nasty alarms going off during the night, and thereby improving patient compliance, especially if you want to give it for 5 to 6 weeks. I think the patient compliance becomes an even more important factor here. And so, I would like to see the industry come up with such devices. To conclude, I think this is something funny I came across. These are the tenets of Hallstatt, sort of proto-commandment by Gillies. Hallstatt, great surgical hero of the 19th and early 20th century. And when I took a look at his commandments for ideal surgical closure, I thought it's funny because it kind of resembles what incisional negative pressure wound therapy does to a wound, because the negative pressure is atraumatic, still it provides approximation, whereas suture techniques are inherently traumatic, albeit on a microscopic level. And there's evidence to suggest that it leads to decreased hematoma formation. It even improves perfusion. Now, it minimizes tension, it approximates the tissues, and it obliterates the dead space. So I think Mr. Hallstatt would approve of this intervention. So thank you all for listening, and I would be happy to answer any of your questions.
Thank you so much, Pieter, for this excellent talk. We do have a question by Smith. Does it mean that interrupted therapy, I have to look at it. There it is. Does it allow dressing changes? That's what the main issue is.
I can read the question. Well, I think it's good to do dressing changes and not give it for 5 to 6 weeks with the same dressing because of the previously mentioned skin maceration, for example. And also, well, you might want to take a look after 2 weeks. Normally, some people, they take a look every day and it's difficult for them to be without a wound inspection already for 1 week. But if you, what they do in some hospitals, they, in the hospital stay after the surgery, they use the hospital pump. And then when the patient leaves the hospital, they, in a clean setting, so not really sterile anymore, but still they they use a technique, but not like the OR, and then they place the disposable dressing upon dismissal to home, and that way you can extend the treatment duration. For example, if the patient is in the hospital for 5 days and you can provide the intervention for 7 days, the disposable one, then you have already increased the total treatment duration with 5 days by using a hospital pump. And maybe if you are lucky, the wound has already re-epithelialized when you do the dressing change. So I'm not against dressing changes per se. No.
And how convenient is this therapy for the patients?
Some patients they report benefit in regards of pain because they feel it stents the wound, and so there's less pull on the. For example, if you have an obese patient and they have a laparotomy incision and there's a lot of weight pulling on their incision, that's not a comfortable feeling. And this similar to a tight bandage, it provides some stenting, but also some patients report unease, and sometimes we decrease the amount of subatmospheric pressure from 120 to 80, if that's the case. For example, so I think what is the ideal pressure, relating back to the discussion beforehand, is multifactorious and also dependent on the elasticity of the tissue, because I think what you are interested in is the final amount of mechanical deformation in the tissue, and the amount of stenting to the tissue. And so it's not about just the subatmospheric pressure, it's about the elasticity and the effect, the interaction, and also patient factors such as, are they comfortable with the subatmospheric pressure that is being used.
Yeah. Okay. Thank you very much. As we have 2 questions left, and this is one by Alexis Desmoulière. Can you also use it for a deep incision?
Well, there's some discussion among the community. Well, how far does the negative pressure reach? I think maybe this question refers to does it treat the underlying tissue? I don't know if I understand it correctly, but
yeah, I think that's what he meant.
Sorry?
I think that's what he meant.
Okay.
So.
Okay. Well, I think if you perform a good closure technique and tight closure technique, and the negative pressure is adequately in place, then it should collapse the tissue such that if this is the depth of the wound and this is the skin, then there is no communication between the vacuum compartment here and the deep compartment here, because this is closed. Of course, in practical reality, sometimes there will be a communication, a gap, and then some of the vacuum suction might reach the lower tissues, but I don't think it really comes that deep. And also we did a study in the AMC, in the complex abdominal wall reconstruction population of Professor Burmeister, people who have large abdominal hernias and enterocutaneous fistulas and such. And there we did not see any treatment effect regarding intra-abdominal infection. Only a really minor suggestion of an effect on deep abscesses, but it really was really effective regarding superficial surgical site infection near the cutaneous incision. So I think it's a nice intervention, and it treats it's good for the incision, but it does not treat the really deep tissue, unfortunately.
Okay.
In my opinion.
Then I would like to end with the last question we received, and which makes the circle round again. Do you think that the negative pressure diminishes the myofibroblast activity?
Yeah, I think it does, in the sense that it stents the tissue side. There's less mechanical stress activating it, I think, and therefore less hypertrophic scarring, similar to silicone sheets or other interventions. So, yeah.
Okay, so then the circle is round. Then we, at the end, it's a little bit past closing time, but I think we were quite well on time all along. So we had three great speakers, three great talks about myofibroblast and about the use of negative pressure therapy for using it on wounds, specifically on incisions after surgery. And I would like to ask Gabriel to put on the announcements to close this session. First of all, it's always nice to share with you the textbook on scar management, which can be scanned. You can see the QR code on the right side, and I think it can be easily found on the internet. Then we have some announcements, one which is for the French SCAR Association and for the UMA, which is international. And there will be a conference in October, which is online, and there's one planned for February. Then also very interesting, there is a conference by the Global SCAR Society in December this year in Tokyo. And the last slide. Oh no, this was the end of today's webinar. I hope that you have enjoyed this, and we're looking forward to the next meeting on Friday, June the 19th, where session will be talks will be given by Sylvie Meom, by Adeshir Bayat, and by Jonathan Omerod. So we are hoping to see you then. So goodbye for now. Thank you.